Supine and prone PCNL. We will discuss here on this small this thing. If you have a kidney, again I am showing the left kidney. If you have a stone in the middle calyx, it may be anterior or posterior, you don't know. So in this case, you come from lateral. If it is the axial skirt, this is anterior, this is posterior. If the stone is come, you can come here. If the stone is there, you can come here through the supine. But in prone, if you come like here, okay, for posterior. But anterior, you cannot come like this. You have to come like this and then go. Sometimes it may not be possible. So if you don't know anterior or posterior anatomy well, and if the stone is reasonable size, see, when you talk about PCNL, all the stones are of reasonable size. Otherwise, you will do RIRS. So if it is reasonable size like this, whether anterior, posterior, supine is better. Because you will come laterally and into the stone, and you can go anterior, laterally, posterior. The coron is here. You cannot hit both together in supine PCNL because it's a horizontal puncture. Whereas in prone, if you come like this, you can hit both. Whereas in supine, you cannot hit both. If you are really horizontal, only one plane you can attack. So either you come here or you come here. Renal vessels will never come significant here.
Fine. The posterior calyx and anterior calyx.
Yes, if it is posterior calyx,
if I do,
you can do prone also.
If you do prone also, I will enter into the posterior calyx
and remove it.
But automatically in the down you have to see the anterior calyx.
No, you cannot see because there will be an angle. If it is because middle calyx is separated by anterior posterior perfect.
Then in supine also you need to do two punctures.
No, in supine both stones are there. You come up to here, then go here, then go here like a aeroplane landing. You can go like this or you can go like this, supine. Whereas in prone, you have to go through the posterior only.
Or two stones are
if
there.
Two stones are there, you remove it. The chances of looking down in supine is slightly more because you are coming horizontally. Horizontal movement is easy. If you come in prone, vertically into the more posterior calyx, you have to go to pelvis, turn back. So if both stones are there, you have to ideally see the anatomy. We are not discussing both the stones. We are discussing single stone. You are not sure whether it is anterior, posterior. You go horizontally with supine, slightly more advantageous.
Only one stone, whether it is in the
anterior or posterior, supine is better. If it is posterior, slightly prone is better. That you have to read carefully anatomy. But sometimes in CT, you may miss it. And that also, if you are missing here one puncture, you can see with RIRS and say that this is not the area of the stone. You go to the other calyx. Then you can travel little anteriorly, posteriorly, changing the track. You can change the track. This is a track, this is a track. This track change cannot be done in prone. You have to only one track to reach one calyx, that is posterior calyx. Now we have same left kidney I am telling, same kidney. Now if the stone is here, okay, it is debatable because in the prone PCNL, if you take the skin, it will be like this. Skin, it is nearer in prone. You puncture like this, you puncture like this, you puncture like this. But the rib can come. Whereas in supine, if it is there, if you go medially to hit it, you have to turn the patient more medially. Turn, because the kidney will be, in the center line kidney will be more like this. That means you have to go more medially, means you have to turn the patient.
You are talking about supine.
Supine. Supine is difficult. Prone, it is nearer to the skin, no structures. Anyway, coastal is not different from both. Prone and supine, you have to travel through this thing. So, in case of medium stone, prone is better. If it is a large stone in the upper calyx, if the patient you don't want to turn, you can hit anywhere here horizontally. And little turn is enough, not much necessary. So in a large stone, prone and supine, no difference. In a medium sign, prone is better.
See, you are telling it is a horizontal puncture.
Horizontal puncture.
So
but you cannot
puncture. Not a caliceal puncture.
No, calyx may be there here.
Calyx
may be there lateral. If the lateral calyx is not present, supine PCNL is not good. But if the stone is very big, nothing will happen if you hit here. Nothing will happen if you hit here. Because there are no major vessels now here. This infundibulum is here only. They are anywhere on the lateral aspect, but that's not ideal puncture. Ideal puncture is what you have to go through the cup. Cup, if it is lateral, supine. If it is superior like this, you can never puncture supine like this. Never. That's why any kidney which has a calyx like this, supine no. Supine no. Unless the stone is too big, so that you will come laterally. You cannot come like this in supine. Impossible. Because this is a transverse horizontal puncture. Same kidney left I am drawing. One pelvic stone is there. You have a nice calices. You can go lower, you can go middle, you can go upper depending on your capability. Some say that upper in prone is the ideal puncture, but infundibular artery will come. Some say that lower is very good, easily we can remove. What is the greatness? Because no anterior, no posterior. But I personally feel ideal cup can be punctured with supine very well from middle. And if it goes here, if it goes here, if it goes here, supine catching is more easy. So single stone 2 centimeters, middle calyx very prominent below the rib, exactly center of the calyx it will go. This, you have a stone here, you have a stone here. Both are medium size. What will you do? See, normally in prone PCNL, if you go from here, the removal of this is easy because this is a normal routine approach. But the only thing is, in kidney, when you see in the middle like this, kidney is like this. So when you puncture from the deeper, you have to go to superficial. Sometimes if the angle is above, to reach here by chance if the stone goes, you may not be able to go above, you have to go because it is superficial. In prone PCNL. When you puncture from the back, if this is the kidney, this is deepest, this is superficial. Once you go very deep, you have to come up to see the superficial. That is dangerous. In prone. But usually what happens, it is in line with this. This stone you remove, this stone you will remove, like the case we did today. Immediately it will come. That's why 90% priority is this. But what about the supine? Same thing if I explain supine, going from the lower to upper is easy. Like in puncturing lower is not easy in supine. That is the unfortunate part in supine. If you go like this, iliac crest will come. If you come like this, your chances of puncturing area is less. You have to be too precise, very difficult. If the stone is big, then you can do supine and remove it. If only these two are there, if you come from the middle calyx, throw the supine, it is very good. I favor middle calyx supine, this remove, and you can easily turn and remove this anteriorly. So turning from here to here is easy, so prone is favored. But if you wanted to do supine, you will do from the middle calyx, go here, remove it, turn here and do it. Whereas if you do like this, it is little difficult. Because puncturing the lower calyx in supine PCNL is difficult. Puncturing the middle calyx is the easiest thing. And one more thing, if the kidney is like this, if the kidney ribs are like this, if kidney is more high, supine PCNL is very easy. Because lower pole will come here, iliac crest above. If the kidney is low, you can't do. This is the biggest advantage of supine PCNL if you are dealing with this case. So if the kidney is high, you will have a lot of space to go into the inferior calyx. Whereas that in prone PCNL may go supracostal. This is horizontal puncture. So in supine, if the kidney is high, good for the lower calyx. In supine, if the kidney is high, lower calyceal stone horizontal puncture is easy. If you want to do like this, puncture in supine is difficult. Usually we go at this angle maximum. You can't go like this. So if you have two stones, if the big stone is there in the pelvis, I will prefer supine middle and then take out the small stone. If the large stone is in the inferior calyx, I will prefer supine and remove this. But if both stones are equal, I will take chance for prone as well as supine equally, there is no problem. But if stone migrates to upper calyx, lower to upper may not be reached in prone. Whereas in supine, middle calyx to upper, lower calyx to upper is easy. And migration is also more in supine. That is the disadvantage. If you are breaking, because it is low down, they all go into the upper. Then you have to go carefully and remove it. So you have to carefully analyze both supine and PCNL. You should not say this is the best.
ఇక్కడ
తెలుగులో మాట్లాడదు రాజా, దిస్ వీడియో యా
అని డౌన్ అడగమంటాం.
చెప్పు. ఓకే, మిడిల్ calyx
they are unable to reach the lower calyx easily in supine PCNL.
See, reaching from here to here is easy in supine. Reaching from here to here is easy in supine. Reaching from here to here is also, you have to look anteriorly but easy because angle is horizontal, not difficult. This is my experience. It may be biased. Anything from middle calyx, prone or supine, movements are easy because this is isocentric with the pelvis. A little above, little down. But it all depends on the angle here. This angle is more from here to here, here to here. Any person it can be difficult. For example, one calyx is like this, upper. One calyx is like this, middle. One calyx is like this, like this. This is the picture of the kidney. If you go from here, you can never reach this. If you go from here, 1 minute. If you go from here, you can never reach this. In that case, RIRS will be helpful and supine PCNL is better. But it should be small stone. But if it is more lateral, it will be difficult for both supine and from lower to upper you can go. Middle to upper, middle to lower. If this calyx is extremely like here, it is difficult to go like this.
I have two doubts in
Yeah.
this. So in this, most of the time, when you are doing supine PCNL,
You will come like this. Yes.
So reaching this stone is also
Easy,
not that
easy.
You are telling it is easy.
Easy.
Another one is, if the two stones are there, which one do you prefer and why?
See, large stone in the pelvis should be priority first. That will I go through the middle calyx supine. After that, this stone I will easily remove it. Anytime pelvic stone should be removed at any cost.
Always prefer
Middle calyx supine for the pelvic stone if it is present. Next combination for supine. Easy fragment removal, need not shift the patient. All general advantages of supine PCNL can be taken because it is no rib, horizontal puncture, no too much turning. Fatapat fragments will come out, and this also come out, and you can inspect any migration can be taken out easily. In prone is the ideal puncture, but infundibular artery will come. Some say that lower is very good, easily we can remove. What is the greatness? Because no anterior, no posterior. But I personally feel ideal cup can be punctured with supine very well from middle. And if it goes here, if it goes here, supine catching is more easy. So single stone 2 centimeters, middle calyx very prominent below the rib, exactly center of the calyx it will go. There is no much anterior posterior here. Any anterior or posterior no problem. Lateral calyx if it is there, for example, it is like this. Okay, this calyx or this calyx is very good for supine. But 90% of the world does prone from the lower calyx. 10% do upper calyx. Whoever does has to go through the calyx only. Here this is the calyx.
Why most of the surgeon discourages this middle calyx?
In Chinese technique, middle calyx is favored, but inferior calyx is used. Many people they think that it is easy. Infundibular vessels will not be there, but that's not correct. If middle calyx problem is anterior posterior separate will be there. In prone, if you puncture posterior, guide wire will not go properly. For example, it is oblique like this. This is anterior posterior. Normally you should come like this. By chance, if you come like this, guide wire will not coil properly. If it goes, it will coil nicely. But if you puncture by chance middle calyx anterior, you cannot do surgery well. That problem will not be there in supine PCNL. You will directly hit anterior or posterior. For example, stone is here. Whether you come from here or here, it can be tackled. But that is not possible in if you go to by chance anterior calyx with lack of technique, then coming back to pelvis is very difficult in prone. This is the reason why pelvic stone through the middle calyx if you want to approach supine. Pelvic stone if you want to approach from inferior calyx, prone. Middle calyx supine for the pelvic stone if it is present. Next combination for supine. Easy fragment removal, need not shift the patient. All general advantages of supine PCNL can be taken because it is no rib, horizontal puncture, no too much turning. Fatapat fragments will come out, and this also come out, and you can inspect any migration can be taken out easily.
If that lateral stone is present in the anterior or posterior,
No problem. Anterior, posterior, any pair, no problem. Supine is better. Next case is again left kidney I am saying, again ureter I am saying. Pelvic stone again I am saying, upper calyceal stone again saying. This is tricky because if you puncture here going like this may be difficult. But prone, everything looks down. Prone means this calyx if you reach, anywhere you can reach. Because it will be oblique puncture which is not possible in supine. So you come like this, remove it and go everything. But one condition, if it is a very small stone, if it is a very big stone, you finish here and you finish this so that you need not worry about the supracostal puncture. To avoid supracostal puncture, if you have a stone here and here, the person of the RIRS will break and give it, whereas the prone PCNL surgeon, supine PCNL surgeon will remove that. In that case, you need not go above 12th rib. Supracostal puncture need not be done at all. If you are
RIRS is not available.
if the RRS is not available, if this stone is large, go for prone. If this stone is small, you can try from here. Because small stone aiming in calyx is difficult in prone and supine. 99% you can go with flexible scope, nephro also you can remove. So PCNL supine is better, but prone, any case can be done with prone. This is only for discussion. Now, multiple stone combinations. Now same kidney I have drawn here, left side kidney. You have a system like this. You have a pelvic stone, inferior calyceal stone, middle calyceal stone. Three stones now combination we are talking. Then we have to see the RGP, very important. If the RGP wide system, all calyces are easily communicable, then supine I will go here, I will remove and this remove. If the RGP is like this with long infundibula with this stone, one stone here, one stone here, you have to go for this separate puncture only. In that case, I will do supine this, then I will tackle this with supine, but difficult. Prone it is easy. This type of stone where long infundibulum stone is 1 centimeter, supine will be very difficult. Whereas in prone you can nicely enter the calyx peripheral tip, prone. So if you want to aim to remove this prone. If you want to aim to remove these two, supine. If both want to remove ECIRS, don't say that it is not available. Best is long infundibula ECIRS. That is the only reason why you should learn supine PCNL. Otherwise, no need to learn supine PCNL. Otherwise, no need to learn the supine PCNL. Next combination is you have a stone here, you have a stone here, you have a stone here. No doubt ECIRS. Here you come, you remove this, you tackle with RIRS. Very easy, you have done many cases. But if you wanted, if the angle is very big, it doesn't make any difference. You can go like this, you can go like this. But any surgeon who want to remove easily these three, they will prefer prone. The only problem is supracostal. Supracostal. If somebody says that I never worry about supracostal, prone. If somebody is worried, then supine, you have to use flexible nephroscope or ECIRS. So wherever ECIRS is available, even now 6.3 French ureteroscope will go, make with high energy 1.5 to 2 joules and 10 Hz, it will make 3 pieces. Those 3 pieces will drop down and they will take it out. Don't do powder. Center of the stone you make 2, 2, 2. Make drill like a pneumatic lithotripter. 4 pieces you give to him. In 15 minutes you can remove it. Whereas supracostal puncture can be removed forever if you are very good in RIRS surgeon. Supracostal puncture you can erase in the history of PCNL if you are unless it is very large stone. Very large stone there is no problem, laterally supine or this. But very small stone, supracostal puncture, very good surgeon, that concept will go. Because that much large stones will not form in the future. That's why you should learn supine PCNL and RIRS. Next, multiple stones. For example, you have a large stone here. You have one here, one here, one here. Only supine ECIRS. No other choice. ECIRS. No other choice. Because you bring this, you bring this, you bring this, you remove from here everything. No discussion here. Same thing, if you have a very big stones here, it is a tricky job. You have to see which angle you can remove maximum, but 2 punctures will be necessary. And if any stone in the upper calyx, if it is small and can be managed with RIRS, then ECIRS, ECIRS, ECIRS. If upper calyx is large stone, prone PCNL from upper, remove everything.
Today's case.
Today's I will tell. Last I will tell. multiple stones are present, okay, is a large stone present, multiple small stones here and there, no doubt ECRS. This can happen in nephrocalcinosis, there is no question. Upper aortic stone, ECRS. Upper aortic stone with these any type of stones, ECRS. One stent before also doesn't make any difference. You need not puncture here. Like another most important in urology is complex system like this with a stone, even if it is big, you should keep in mind RIRS. It is very easy in future to deal this type of the stone in RIRS than perfect puncture in prone or supine PCNL. This long infundibula, for example, I will say like this long infundibula is the most dangerous thing for the PCNL. Here if it is stone is present, here stone present, anterior, posterior, suddenly you puncture here, disastrous bleeding happen, only RIRS. If RIRS you are doing mean any stone here you tackle with PCNL. Nowadays these stones are also tackled with RIRS. Overall PCNL role is also decreasing. So you have to be careful. More than 2 cm stone with small stones, supine PCNL is better. Now coming to the last point, Staghorn calculus. In the Staghorn calculus, what important is, Staghorn had two types. This is the calyx, this is the calyx. You have completely stone. Up to here. Only advantage of prone is you look down and break. So that breaking is easy and removing is difficult. Removing you can remove actively, but breaking every time if you are horizontal, you have to look up or horizontally breaking is difficult and water leaks. In supine. So Staghorn I will prefer prone PCNL because anywhere you hit no bleeding. But in one condition there is a difference. If it is like this, Staghorn is, and this is a stone, and each stone is going into this. This is very difficult for like anything. Simple big Staghorn is not at all a easy, not at all difficult case. These are the most difficult cases where anatropic nephrolithotomy is indicated. Whereas here you have to see lot of people go if the infundibulum is good from above and then remove as much as possible. They will do 1 or 2 punctures. After that they will do 1 or 2 punctures. But in still prone PCNL is better. But if you supine PCNL, you can come here and remove all that. If any senior RIRS surgeon can break this faster, you can spend some time with nephrostomy and then do ECRS, but ureter will be affected when such large volume is done. So to conclude, dear friends, urologists, don't get carried away with the supine PCNL and prone PCNL. The one important concept is lower calyx facing down. Supine PCNL cannot be done easily. Middle calyx puncture supine PCNL is easy. Upper calyceal facing up towards the head, supine PCNL is difficult. The thing is, stone sizes are becoming small and they are multiple. So any stone in the pelvis, if you can come with the middle calyx, rest of the stones can be tackled with RIRS surgeon. That is called ECIRS. That is the entire funda of supine PCNL. Otherwise, alone supine PCNL, very few cases it will be advantageous. Is my experience after doing 15 years of prone PCNL, 4 years of 5 years of supine PCNL, and now last 1 year I am doing alternate case prone and supine. With this experience I am sharing this video. Thank you very much.